Morning, my name is Abdelilah el Barzouhi and I'm a medical doctor and researcher at the Department of Neurosurgery at the Leiden University Medical Center in the Netherlands. I have the honor to give a presentation about the association between vertebral endplate signal changes, also called modic changes, and back pain in patients with sciatica. The basis of this study was the trial of local pill. The trial compared an early surgery strategy versus prolonged conservative care for patients with sciatica. The trial showed faster recovery after early surgery as compared to prolonged conservative care with surgery if needed, but there were no differences in outcomes after 1 year. All patients in the sciatica trial underwent MRI at baseline and after 1 year follow-up. This gave us the opportunity to study the presence of modic changes in patients with sciatica, their behavior over time, and their correlation with back pain at baseline and after 1 year follow-up. In 1988, Modic described 3 types of modic changes. Type 1, decreased signal on T1 and increased signal on T2 images, and they are supposed to reflect an acute process. Type 2, the most common type of modic changes, increased signal on T1 and T2 images, and they are supposed to reflect a chronic process. And you also have a type 3, it's very uncommon, and then you have a decreased signal on T1 and T2. Of the patients who displayed modic changes at baseline, 40% reported back pain, as compared to 38% of the patients with no modic changes. This was at baseline. But now we perform surgery. This figure shows the prevalence of the different types of modic types at baseline and after 1 year follow-up. What we learned from this figure is that at baseline 1% had modic type 1, and that increased to 35% after 1 year follow-up. So surgery really progressed the development of modic type 1. In conservatively treated patients, modic type 1 increased from 3 to 11%. And modic type 2, which is supposed to reflect a chronic process, stayed almost stable. What we learned was that back pain, in fact, diminished over time. Here you see a figure showing the evolution of back pain in surgically treated patients according to whether the patient had or had not modic changes. In both groups, back pain diminished after inclusion at baseline, with no differences in the rate of back pain at 1 year follow-up. Same results in patients who were treated conservatively. Here you see a figure showing the prevalence of back pain in patients with no modic changes, it was 12%, in patients with modic type 1, 16%, in patients with modic type 2, 11%, and in patients with both type 1 and type 2, 3%. There were no significant differences in the prevalence of back pain between the 4 groups. And what about the extent of modic changes? At 1 year follow-up, 67% of surgically treated patients showed an increase in the extent of modic changes as compared to 19% of conservatively treated patients, a remarkable odds ratio of 8.6. But patients with an increase in modic changes did not report more back pain. So our conclusion was that surgery for sciatica was highly associated with the development of modic changes after 1 year, especially type 1. but that in contrast to our intuitive feeling, those with and those without modic changes reported dissolving back pain in nearly the same proportion. Therefore, vertebral ankle signal changes do not seem to be responsible for the dissolving back pain in patients with sciatica. I would like to thank two authors, Rukkel Pulm and Carmen Blanca, who unfortunately could not be here.